In accordance with the customs of this university, I open the ceremony with a prayer. Spiritus Sancti Gratia, illuminat sensus et corda nostra. Please be seated. Ladies and gentlemen, it gives me great pleasure to welcome you at this ceremony at which Dr. Naghibi Beidokhti will defend his thesis. My name is Van Weel. I'm Emeritus Professor of General Practice at the Radboud University, and I replace at this ceremony the Rector, Professor Van Krieke, on behalf of whom my word of welcome is, of course, a very special welcome to Mr. Naghibi Beidokhti. I think I'm speaking on behalf of all of us when I wish you lots of success in defending your thesis, but above all, lots of satisfaction from discussing it. I will give you in a moment the floor, but first I would like to ask everyone to make very sure that all mobile telephones and other technology is switched off so that we are having an undisturbed ceremony. Then the floor is yours, Mr.
Thank you, dear Rector. With the permission of the Council of Deans, and in order to obtain the degree of Doctor from Radboud University Nijmegen, I would like to defend in public my doctoral thesis entitled Personalized Finite Element Models of the Knee Joint, a Platform for Optimal Orthopedic Surgery Pre-Planning. The knee joint is one of the most complex joints in the body. Besides the bony segments, articular cartilages facilitate the motion of the bony segments on each other, which covers the femoral condyles, as you see, and also tibial plateau. Moreover, there are two collateral ligaments on the either sides of the knee joint, and also called MCL and LCL. And also there are two cruciate ligaments in the middle of the joint called ACL and PCL. The ligaments constrain the motion in different directions, preserving the movability or the laxity needed for daily activities. The knee joint is very vulnerable to injuries. Rupture in ligamentous structure, damage to the cartilage and menisci are amongst the most common injuries in the knee joint. Besides the direct damage to the cartilage, the injury can cause mechanical instability, which can lead to osteoarthritis in the joint, which is also followed by lots of pain. It's believed that mechanical factors contribute mostly to the initiation and progression of osteoarthritis, and computational models were shown to be effective tools in assessing these mechanical factors. And more particularly, finite element simulation can provide highly detailed information on especially the soft tissues biomechanics. The aim of my thesis was to develop a personalized computational platform based on finite element simulations to be used in clinic as a surgery pre-planning tool to improve the outcomes of the knee orthopedic interventions. In general, my thesis consists of three main parts. In the first part, the essential aspects in finite element modeling of the knee joint were assessed. In the second, two methods to non-invasively estimate the mechanical properties of the ligaments were suggested and studied. And the third part, the developed finite element models were implemented in two clinical interventions. So as mentioned, in the first part, the crucial consideration in enhancing the prediction of finite element model of the knee joint were evaluated. First, in the study presented in Chapter 3, different approaches in modeling ligaments were assessed. Traditionally, ligaments were modeled as straight line, string elements actually, and where some others modeled that as 3D volumetric ligament. Also, in terms of mechanical properties, the properties of the ligament can be assigned based on the previous study, based on the literature, or they can be tuned with a personalized level, so differently for each patient. To assess different ligament modeling approaches, as mentioned, we use cadaveric knees, model them in finite element with different ligament ligament representations. To evaluate which ligament model is more valid, the prediction of each FE model in terms of motion of the knee and also contact pressure at tibial plateau was compared with experimentally measured one. The result revealed that to have valid prediction of finite element model, the properties of ligament needs to be assigned differently for each subject. As you see, for instance, here, we see cadaveric knee is being flexed, and these are the experimentally measured contact pressure, and in the lower one, you see the prediction of FE model. In addition to the main ligaments, there are other peripheral ligamentous structures that may influence the knee joint kinematics, particularly at the backside of the knee joint. In most finite element models, these structures are ignored. In the study presented in Chapter 4, we applied the same loads to cadaveric knees before and after removal of these peripheral soft tissues, and we compared the motion or the movability or laxity of the knee joint in two cases. And our results reveal that indeed it's not always a good assumption that these peripheral soft tissues are ignored. In the second part of the thesis, two methods to non-invasively characterize the knee ligament properties were studied. As a part of a study presented in Chapter 3, basically we applied some forces to the cadaveric knees, as you, for instance, you see in the animation, and we measured the motion of the knee joint. Then in the finite element model, we applied the same forces, and by playing with the mechanical properties or coefficient of ligaments, we tried to replicate the same motion as measured in the experiment. Although this method could successfully implemented in cadaveric setting, the whole process took more than a month, which might make it impractical in clinical implementation. Therefore, in Chapter 5, it was assessed whether the mechanical properties of the knee joint ligament can be estimated directly from MRI. For this purpose, some parameters from quantitative MRI were extracted for ligaments, and also the ligaments were segmented from MRI to be able to estimate the volume of the ligaments. And eventually, we pulled the ligaments, isolated ligaments, we pulled apart up until rupture to estimate the stiffness and strength of ligaments. And the result illustrated that there is a meaningful correlation between the MRI parameters combined with ligament volume, with the stiffness and strength. And the last part of the thesis, two clinical interventions were evaluated using subject-specific finite element techniques. ACL rupture is a common injury in the knee joint. Usually patients with ACL rupture undergo ACL reconstruction surgery, in which the torn ACL is replaced with a graft, as you see in the animation. However, there are different parameters available for the surgeon, and more importantly, from a mechanical point of view, the graft insertion size, so the graft can be positioned differently, and also the tension applied to the graft prior to the fixation can be quite different. So in the study presented in Chapter 6, we used cadaveric experiment and finite element modeling to optimize for this specific subject, to optimize these surgical variables. So to find the optimal insertion size and tension of the graft, a relevant force was applied to the cadaveric knee with the intact ACL, and we applied the same load to the grafted knee model, and with playing with the surgical parameters, we try to replicate the same motion again to the cadaveric experiment. As for instance, you can see these are the optimized insertion sites for different grafts. To verify if we could, let's say, improve the outcomes of the surgery based on the forces extracted from in vivo, we applied the forces to the knee model, and after assessing the kinematics and contact pressure tibial cartilage, we actually it was revealed that indeed the let's say the biomechanics of the joint was recovered. And in the study presented in chapter 7, as the second orthopedic intervention, the positioning of a meniscus prosthesis as a replacement for severely injured medial meniscus was studied. In the study presented in chapter 7, based on finite element simulation, it was shown that malpositioning of the meniscus prosthesis can alter the knee biomechanical outcomes. And that brings me to conclusion. So in the thesis, finite element models of the knee joint with personalized properties were developed for a wider range of clinical application. Subsequently, a workflow was developed to practically implement finite element models as a surgery pre-planning tool in the knee orthopedic interventions. However, whether these modeling techniques have clinical benefits required long-term clinical studies. And with this, and having presented this summary of my doctoral thesis, I return the floor to the director.
Thank you very much for this summary. Ladies and gentlemen, the first step on the road to the doctorate is the completion of the manuscript you've just heard summarized. And three persons directly on my left-hand side played an important role in that. The reason that I would like to introduce them now to you is that in the following steps, the dialogue is sought with people from outside the research group. There are Professor van Donschot, Professor van den Boogaard, and Dr. Janssens, promoters, co-promoters of this thesis. In the next step, the manuscript is assessed by a committee of experts from outside the field, from outside the direct group. And when that committee, the manuscript committee, is given a positive opinion on the scientific quality, the candidate is invited to defend the work in public against the members of the committee and others from the field. And that's what we are going to do now. And as first, I would like to invite Professor Karstenmeijer to examine the candidate. Professor Karstenmeijer is Professor of Computer-Aided Diagnosis at the Radboud University and Chair of the Manuscript Committee. Professor Karstenmeijer.
Thank you very much. First of all, I would like to compliment you with this beautifully written thesis in a field where I'm not particularly an expert, but as a physicist I can still judge, I think, partly the quality of your work, and it is quite impressive. I'd like to ask you just some basic questions and then give the floor to the real experts. But to understand a little bit more about the implications also of what you've been doing, I'd like to discuss with you figure 1 in the discussion on page 164, where you have a nice overview of where this field is going. And I have some questions about that, particularly in the field of MRI, because I'm also working in radiology. So you base your whole finite element model of data that you obtain from MRI, and the MRI you make under certain conditions. And I believe you put some forces on the knee during the MRI to simulate what's going on when it's in movement. My first question is how realistic is that? Are the forces, because the patient's lying in the MRI, I can imagine that is quite different than when someone is playing football on the field. What do you think? Is this really realistic, what you try to measure there in the MRI?
Dear Honor, sir, first of all, thank you very much for your kind compliment on the thesis. In regards to your question, indeed, that's one of the challenges in expanding the workflow we develop in this thesis to in vivo. However, as also described in chapter 3, the forces we apply to characterize the knee ligaments are not very high forces, and they can be safely applied to the knee of the patient while he or she is laying on the MRI bed. And to be able to, however, applying the force, an apparatus to apply the force is also a challenging part, because it should be MR compatible and it should have a very good control on the amount of force and also the direction of the force we are applying. I think in the figure you mentioned, it's not really feasible, but in the figure A1A, we had a kind of MR apparatus we bought for this project, with which you could apply sufficient loads needed, probably sufficient loads needed for characterization of the knee ligaments for patients. So you could apply different torques, you know, and also some anterior-posterior loads. So I think that should be enough for characterizing the knee ligaments. Okay. And for validation, we need a more realistic daily activity. Then maybe we can use the standing MRI for further evaluation of the developed knee.
You do the validation in another way, right? In the
yes,
figure
exactly.
I see, you have like normal activities, and then you use ultrasound, and then you do some kind of validation.
Exactly.
I was also interested in, so then you build your finite element with some registration. You look at what's going on when the knee flexes and so on. But then you have also real measurements from the ultrasound and what you do from the other branch. Are you only using that for validation, or can you also do you also use that to kind of optimize still your model?
Actually, ideally, what we optimized based on only the laxity test performed in the MRI should be, the result of that model should be valid for, let's say, for later experiment, validation experiment. So I would suggest to use only MRI and the apparatus for laxity test and optimization, and use the ultrasound and also A-mode ultrasound as described in the discussion.
Just for the validation?
Just for validation. Otherwise, if we optimize our model based on all of these, then still we need some other maybe activities for our validation.
Then, yeah, finally for this graph, so you, of course, you have some two nice applications in chapter 6 and 7, I believe. But there are probably many other applications. Could you also think of like optimizing, for instance, the prosthesis, making that patient specific? Is that already done in this field, or?
That's exactly, that can be an application for this model. However, as also discussed in the discussion chapter 8, if we would like to look at, let's say, the detailed prosthetic design, we need to have a more realistic representation of the bone to be able to look at the micromotion between prosthesis and the bone, and also, let's say, stress shielding, loosening, let's say, risk. But in terms of geometry, indeed, I think that can be, let's say, implemented for prosthetic design, as implemented, for instance, by Baldwin et al.
Is there time for a short?
Yes, you have time for a short question.
Okay, one short question, and it's a little bit more technical about chapter 5, but no doubt there will others be discussing this also with you. But I was just one question I have as a physicist. I look at your data analysis, and so I'm doing machine learning, and they're trying to prevent that you overtrain and overfit on your data is always very crucial. And I see you use 6 patients here. You have then 4 times 6, I believe, ligaments that you have in your figure, but you still use a linear model with 3 parameters. So that's kind of some fitting going on, I would think, also in your choice of the which is it volume, cross section, is it you kind of optimize. So how well do you think this will reflect this match to really new data?
I totally agree that other parameters can be included also in the parameters we assess in this study. However, as also I think mentioned in the discussion of this chapter, for instance, beside the type of ligaments, if we incorporate the intervariability of different cadavers, in this case, let's say the prediction could be improved. but the number of the data points were not enough to include more parameters. That's why we decided to, let's say, incorporate the crucial or more crucial parameters. But for sure, for instance, the load which is applied to the ligament can also be included in these correlations. But we need more specimen, I believe.
Okay. Thank you very much for your answer.
Thank you very much. Then it gives me pleasure to welcome in Nijmegen Professor Vena. Professor Vena is Professor of Biomechanics at the Politecnico di Milano in Italy, also a member of the Manuscript Committee. Please examine the candidate.
And thank you also for the very nice presentations and also the excellent piece of work. I enjoyed reading it very much. Okay, all chapters are actually equally interesting, but chapter 5 is the chapter I want to focus my questions. I have one general question and one more technical question. The general question is the following. In a previous chapter, you mentioned that the continuum-based model for ligaments are a little bit better than one-dimensional models. So, and in chapter 5, you identified the parameters for the one-dimensional model. Would you do further research to find also identification for the continuum model, and if yes, how would you do that?
Dear Honor Sir, first of all, thank you very much for your kind compliment, and also thank you for traveling the long distance for us. In regard to your question, actually, indeed, the continuum model in finite element simulations, we showed that if you use continuum model, that the prediction would be more valid. However, the aim of the study presented in chapter 5 was to find the structural properties of the ligaments. And I believe having these, let's say, characterization curve as let's say, not linear, but one-dimensional characterization curve, and incorporating the cross-sectional area, it can be expanded to continuum model. Or we can use the, for instance, cross-sectional area to expand it to the model proposed by Jeff Weiss et al. However, here, that's only the characterization of the springs, not implementing them in finite element models. I would definitely use the continuum model if I want to use these data. These data can be expanded to continuum model, I believe. However, that needs more accurate, let's say, estimation of the cross-sectional area of the ligament.
Okay, so that comes to my second question. Actually, this is a point that I did not fully understand in your answer right now, because one of the parameters that you use for fitting, the parameter is the volume, right? The volume of the ligaments that you estimated from,
yes.
Yeah. So, but if I think to basic solid mechanics or structural mechanics, the stiffness of a uniaxial element is a cross-sectional area. And instead, well, the length is inversely dependent on the stiffness. So I did not fully understand how can you manage cross-sectional area role and volume role.
Okay, actually, so you mean if we incorporate volume, that's already somehow in reverse influence of the stress-strain curve, or maybe I missed?
No, I mean, what I mean is that if you use volume, you have the volume is the cross-sectional area times the length. Huh?
Yes.
But those two parameters are they plays different roles for the stiffness.
Yes, indeed. Actually, for the collateral ligaments, especially for LCL, for instance, we could easily find the cross-sectional area by having the volume, and the length was quite straight, kind of cylinder, kind of. But for cruciate ligaments, either based on the segmentation or based on the ultrasound measurement, we couldn't easily estimate the cross-sectional area from them because it was really complicated structure. So for LCL, we tried that, and we saw that the strain-stress curve makes sense. But for especially ACL, we had a lot of difficulties. That's why we used the global strain versus force.
Okay, thank you very much.
You're satisfied with?
Yeah.
Okay. Thank you very much. That gives me the opportunity to continue the examination by inviting Professor Koopman. Professor Koopman is Professor of Biomedical Engineering at the University of Twente. He was also a member of the Manuscript Committee. Welcome in Nijmegen. Please
Thank you, Mr.
continue the
Hector.
examination.
Thank you. Dear candidate, I really enjoyed reading your thesis, and it's a very nice example of how expertise from different disciplines, from different groups and even different institutes may result in excellent research. However, there remain some questions, of course. I would like to start with a very short question on the figure 3 on page 47. I was a little bit surprised when I saw this figure. There's a lot to ask about it, but what struck me at first glance was that there seemed to be a negative stiffness somewhere in the experimental varus valgus moment. Well, that's very odd, I would say. How would you explain that?
Dear honored sir, first of all, thank you very much for your compliment. And in regards to your question, that was actually one of the points of question after doing the experiment. I believe during applying the valgus varus force, in this case valgus force, probably the location or the relative position of the joint could be influenced, and it can be so, especially because the lateral plateau has a convex shape. It can be that it's due to the slope of the lateral plateau, but yeah, I think
imagine what would happen if this would occur in real life. Then if you would have a small rotation, then it would immediately it would be unstable.
Yeah, it can be. However, I think that also can be because of the direction of the applied valgus varus, because we applied the moment manually, and it could be that even the amount of valgus varus moment, maybe it's less than the previous step. But beside that, although the amount is not that considerable, but beside that, I don't have any other explanation for that. And that was also a point of actually question for us.
Yeah, okay. Some research left there, then, I guess. Sure. Next question is more about chapter 2, in which you compare explicit and implicit finite element modeling. And you state that the femoral and tibial cartilage are modeled with an elastic isotropic behavior, as well as the menisci. And well, so if it is elastic, then I would expect that if you apply a load on it, that you wouldn't see, as you have in figure 2, this overshoot and a damping behavior, because if it would be pure elastic, you would not have damping. And now I saw that you had in your explicit solver a bulk viscosity parameter, which would explain perhaps this behavior. Can you explain me that more? Because where is this bulk viscosity located? And especially if you have it in an explicit solver, what happens in the implicit solver? Because there you also expect something like this.
Thank you. Actually, indeed, as you mentioned, we think the damping behavior is due to the viscosity bulk parameter in explicit solution. However, in implicit, I think that can be due to the friction we applied, because in this, first we use the frictionless contact condition, and we had still some problem with the convergence in the implicit. And then we increased the friction coefficient to, I think, 0.01, and probably it can be the reason for such a damping.
Oh, that's strange, because then if it would really be the friction, then you would not expect that the implicit and the explicit solver would show the same frequency of the behavior. But it clearly is the same frequency. So how would you explain that then?
In terms of frequency, I cannot
so
really.
The one cycle is about 0.2 seconds in these graphs in figure 2.
Okay, in terms of frequency, I cannot really compare them here, whether they have really, I mean, there is any kind of influence on the frequency, or there is kind of deviation. But actually, the only explanation for such a damping in implicit, to me, would be friction, and I cannot think of any, because indeed the model lacks the viscosity in implicit solver.
Do you have an idea where you could find this damping behavior in real life? Where is it located? Is it in the cartilage? Is it in the menisci, or somewhere else?
In the real life?
Yeah.
In the real life, I think that can be mainly due to the viscoelastic properties of the tendon, ligaments, and also diffusion of the liquid in the cartilages and menisci, probably, which is also can be explained or can be modeled by viscoelastic.
I'm not sure about that, because did you ever try? Well, small experiment in mind. I don't ask you to do it yourself, but keep your knee straight and jump off this little edge here, and just by keeping your knees, probably you don't do that, because it's a bit hurting. So if it would be in the cartilage, then there would be too little damping. Cartilage is 1 millimeter, and you need a collision zone. In a car, if you would have a collision zone of 1 millimeter, then it wouldn't help.
Yes.
So you need some distance.
Yes.
So where's the real mechanism?
So I'm not sure if I understood that, because in the real life I've understood that that cannot, let's say, happen, but by the real distance you mean the...
Yeah, because you don't have too much space to have a large deformation in your knee. You can only deform very little. So there's no way you can lose all this energy.
Yeah, I agree. I don't know, I think maybe the amount of force goes to the knee joint is less due to the, I don't know, some pre-contraction of the muscles, which can also help damping the maybe higher forces. But whether or not the whole force goes to that thin cartilage or not, that's what I'm not sure. Maybe by contracting the muscle around the knee, let's say that can be reduced.
I think you're on the right track now, because you mentioned the muscles. I think that you are rotating your joints,
yes.
and in that way you can use your muscles as dampers.
And by the way, in this brings also me to one of the limitations of this study presented in this chapter, in which I fixated the flexion extension. So indeed, maybe if I release that, we could see also some flexion extension, whether or not that helped.
Okay, thank you very much.
Thank you very much, Professor Koopman. Then it's my pleasure to introduce Professor Zatpour. Professor Zatpour is Professor of Biomaterials at the Technical University Delft. Welcome, Nijmegen. Please continue the examination.
Thank you, Meneer Director. Dear candidate, I also enjoyed reading your thesis, and like some of my colleagues, I liked Chapter 5 particularly. So let me start with a general question. We know that for bone, we use the gray values in CT images to correlate the mechanical properties with what we see on the images, and the basis is the bone mineral density, which is affecting the attenuation coefficient in the X-rays, and that's why we know that that's how it works. Now, the question I would like to ask is that how does it work in magnetic resonance imaging?
Dear Honor Sir, thank you very much for your compliment and for a question. In regards to your question, indeed in CT, actually that was the basis for this study. We thought if with CT we can do that for bones, maybe there is a way to estimate the property based on MRI. And after searching more in literature, we found out that it was already studied, as also cited in this chapter. Actually, we don't know exactly how, let's say, the biochemical or maybe biomechanical properties of the ligaments can influence some of these quantitative MR parameters. What we thought is that if any tissue with any mechanical properties has a unique, probably unique quantitative MR value, why shouldn't we try this to see if we can use this, let's say, principle to estimate the properties of ligament? Where does it come from? Still we don't know. And
So since we are doing some experiments, let's take it together and see. So do you know what MRI measures? What does MRI measure? In CT we measure attenuation of X-rays. What do we measure in MRI? Do you know that?
that's the spinning of the hydrogen, I think, molecules
The
by
nucleus of
applying the
hydrogen.
magnetic.
And most of the hydrogen is coming from
Water.
from water. So we
Yes.
are basically mapping water.
Yes.
So is there any reason in your mind that water content might be related to the mechanical properties of soft tissues?
What comes to my mind is that if ligaments has water in it, the more you stretch it, probably at least to in terms of force, maybe the content, the water content can be reduced. But how it can be, let's say, correlated to the mechanical properties, as I mentioned, that's what we don't know.
Do you know, hydrogen atoms are positive, water is highly charged, and where does it go? Right? If you think about cartilage and ligaments, they are attracted, if it's a positive charge, it's attracted to negative charges. Do you know what kind of negative charges we could expect in cartilage, in ligaments, specific molecules that have negative charges?
In that respect, I'm afraid, because this was also a collaborative study with our also MRI expert, Dr. Mazzoli. I'm not fully aware of all the details of.
So you know about GAGs, proteoglycans?
I've heard that and I've read some, but not in details. Yeah.
Yeah. So proteoglycans could attract water, which is why you. So the more proteoglycans you have, you will be having more water, and that's why you will be seeing higher water content. But proteoglycans are also responsible for they have different functions.
Mm-hmm.
For example, one of that is mechanical regulation, mechanical properties. So I would say you are on the right track by doing this magnetic resonance imaging, but then you probably are looking at that. Now, that being said, if you can go higher in intensity, you might be able to measure more sensitive things like sodium content. And then in the sodium content, that might even be more sensitive to proteoglycans, and that might give even a better mapping of the mechanical properties. But then you would need more like 7 Tesla machines to do that.
Okay. Thank
Mr.
you.
Shaman, do I still have time? Or?
Yes, you have time. Don't make it too long, but you have time.
Yes. So if we look, since that went fast, quite fast, let's go to chapter 140, where you show a comparison between the intact and operated on and implanted joints, and you show a comparison. And we see higher or lower forces or pressures. Suppose this is, let's assume that these are real, actual values. What are we looking for? When do we know that the implant is doing well? When there are high forces or lower forces, and where should they be?
Okay, thank you. Actually, if based on the review study by Farshid Golak et al., the maximum or the peak contact pressure can contribute to the progression or initiation of osteoarthritis. So what I would look at in this image would be first peak contact pressure at the tibial cartilage. And also, after that, in the second priority, increasing the contact area is what we expect from the implanted knee, which maybe not that obviously, but at least in the model, we observe that.
Thank you, Mr. Scheller.
Thank you very much. Then it's my pleasure to welcome in Nijmegen and to invite to continue the examination Dr. Blankenvoort. Dr. Blankenvoort is Assistant Professor of Orthopedic Research at the Amsterdam Medical Center. The floor is yours.
Okay, thank you for inviting me in this opposition. I really enjoyed reading the thesis. I compliment you on your work and achievements because of my personal experience. I recognize the enormous amount of work that is required to perform the experiments, make the models, and do the enormous amount of simulations. In particularly, the optimization requires a lot of calculations. I have some critical issues that I wish to discuss with you. As regard to chapter 3, you state an optimization is applied to tune the ligament material properties and initial strain in the finite element model of the knee. And in the discussion on page 52, you state in the optimization process of both the spring and continuum ligament representation, for some ligaments the parameters varied noticeably within the defined bounds. So my first question is, I cannot find these bounds that you mentioned in the method sections, nor in the results. So what are these bounds that you applied?
Dear Honor, sir, thank you very much for your kind compliment and for your question. And thank you for your very nice studies, which we frequently cited in this thesis, and actually for some chapter was the basis for our studies. In regards to your question, the bound and also the mean values with which we started our optimization came from the study of Boulter, which you also used for your spring representation. But when we look at other studies as reviewed by Galbusra et al., who use also the model of or the values from Boulter, they extended the bounds a bit more. Okay. And I didn't mention the bounds here, but I believe I mentioned I think the references which could be checked. However, maybe it was better if I also presented them in the chapter.
Explicitly, yes.
Yeah.
Okay. So now for the results. Table 2 on page 47. So let's have a look at knee number 2. The reference strains. After optimization of the IMCL, there's a number there that states 0.26. You find it?
Yes.
Reference strain, knee number 2, the column IMCL 0.26.
Yes.
Okay. So apparently this means that in the knee's reference position, and because that is what the reference strain are, that is the strain in the ligament in the unloaded extension of the joint. Correct? So the tissue strain is 26%. How does this relate to the failure strain of this ligament or ligaments in general?
Okay, thank you. Actually, if you look at the results, there are also some values or some results in which the stiffness was lowered down and the initial strain was, tuned up. And we also realized that maybe we could prioritize or somehow constrain some of these values because still we don't know if the combination worked good, but whether or not each of these values make sense or not, that's something else. Especially one of the needs we used in this chapter, we used for ligament testing presented in chapter 5. And we saw that there was quite differences between the values we optimized and the real mechanical properties. And we believe that in the optimization somehow the influence of other factors, maybe other tissues or other factors, were compensated, and more importantly, has also studied the insertion sites of the ligaments, which could not be, accurately estimated from MRI, and even after digitization of the insertion, still there are some. Especially, this is the spring model.
No.
So
Well,
that's.
the spring model,
I think
but-
in discussion we also discussed that the error or some non-sensible values can come from the error in the insertion site, which could be also included in the optimization, as I think study also in one of your papers.
Yeah, well, that's correct, but you said compensation in your answer. And so the knee model is a bone ligament bone model with menisci, which is good, but not with all the structures that are transferring loads. So in this case, you compensate for the structures that you lose, that you do not have in the model. That is the compensation. I do not agree with you on the ligament insertions. But on the other hand, during the simulations, also in the continuum model, you have strains in the ligaments, you have strains in the menisci and in the cartilage. Did you check on the strains in the ligaments, and do they exceed the failure strain of ligaments, which is in the order between 5 and 10% where the ligaments start to fail?
Thank you. For continuum model, we indeed check the maximum stress in the ligament, especially
Stress,
because
but not
we
strain.
use
Stress, but not
stress.
strain.
No, not strain, but the stress. Because we use Holzapfel model, and you know that it increases in stiffness exponentially. So we should, keep an eye on the maximum stress, not to exceed the failure stress.
Okay. I do
For
not
ACL,
I do not agree, because ligaments do not fail by stress, ligaments fail by strain.
which is related to the stress.
Yeah, okay, good.
So that's,
You're right. Okay, something totally different.
May I ask with an eye to the time?
Yes? No?
Please.
Just a quick question?
A very quick question, if you can a very quick answer as
A
well.
quick answer on figure 3. In both figures,
sorry, the chapter
figure 3 on page 47, the same chapter, yeah, at the zero load condition, you have 2 measurements and 2 model simulations. Yeah, so with various valgus and with internal and external rotation, you have 2 data points with zero load.
Yes.
Can you explain that to me?
Sure.
Because in a model that would be
That's-
impossible.
Yeah, that's a known fact for the ligaments, which they show a kind of hysteresis behavior. So if you load them and unload them, they doesn't go back to the 0 point in a strain. But if you keep loading and unloading cyclic, that can be decreased.
Okay. And in the model, does have hysteresis?
In the model, no, we didn't have hysteresis.
Okay.
In the model, in the model, when you load let's say flex the knee,
Yeah.
and extend the knee with all the loads we applied, they didn't come back to the original position.
Okay.
Not due to hysteresis, but due to the maybe changing in the contact.
So there's time-dependent behavior, in fact, or load direction-dependent behavior.
Or path dependent.
Path-dependent.
Path
That's the
dependent.
correct answer. I'm very satisfied. Thank you.
Thank you very much. And that's, for me, the opportunity to invite Dr. Coeta to continue the examination. Dr. Coeta is orthopedic surgeon at the Canisius Wilhelmina Hospital here in Nijmegen. The floor is yours.
Thank you. I feel very privileged to be here. I've read your thesis with great excitement and enthusiasm, because it gives a lot of clinical opportunities in the future, I think. I noted you submitted some of your articles to orthopedic journals, and I must warn you that you tend to overestimate orthopedic surgeons, I think. My questions will be on the clinical chapters, and my first question is very simple. It's on chapter 6. You state that there's different graphs you can use for ACL reconstruction, patella tendon, hamstring, and quadriceps tendon. In my clinic, we use all these graphs, but we don't have a clear algorithm for what to use on primary reconstructions. So my question will be, if you yourself had an ACL rupture, what graft would you choose, and what would you advise your orthopedic surgeons to do?
Dear Honor, sir, thank you very much for your very kind compliment. If I have an ACL rupture, for sure, I wouldn't select my graft type. I would go to the knee surgeon. I would ask him or her what their suggestions. That's my if it's the answer.
Okay.
But if
So you'd be the ideal patient.
Yeah, but we believe with this study we can help, not as a patient, but as a computational modeler, we can help the surgeon for any type of graft he or she selects based on their experience, we can help them finding the optimal insertion variables, insertion sites, and also the tension in the ligament prior to the fixation. And if they have any preferences in the surgery, we can incorporate that in the model.
Okay. Yeah, my next question would be about that as well, because in surgery you tend to select the ideal positioning for your bone tunnels, of course. In real life, it's not always as accurate as in the models, so you can be off by a couple of millimeters easily. In the table in chapter 6, you present the peak pressures in femoral and tibial cartilage. And then it says that even if you're on a non-optimal position, you can have higher loads, but not in all cases. What would you think, these higher loads can of course result in developing osteoarthritis in the long run. Do you think other factors are influencing the chance of osteoarthritis as well?
Okay, thank you very much. First of all, let me go back to what you mentioned, the tunnel. That's one of the limitations. I think we also mentioned that in the discussion. That was one of our limitation or suggestion for later study, that the tunnel also needs to be modeled. Here we used a screw fixation at the tibial or femoral insertion site, but in real life, maybe endobutton fixation is more preferred sometimes, which needs to model also modeling the tunnels. And I believe there are at least 30 different way of tunneling which can influence the outcomes. So in that sense, it's more kind of feasibility study, I would say. And in terms of osteoarthritis, not only the maximum contact pressure, but maybe the location where the maximum pressure occurs can be important, because the thickness of the cartilage might be important. If the thickness of the cartilage where the contact is occurring is too thin, maybe still there is a chance for osteoarthritis, which brings us to also reducing the instability and constraining the knee to be at the optimal position, on the intact position. So I would say not only the peak contact pressure, but also the location where the pressure goes to.
Can I ask another question? I don't want
short
to
one.
offend Peter,
If a
because
short one, you
we
are.
work a lot
Yes.
together. In surgery, you always see cartilage damage, usually on the medial femoral condyle, in both ACL patients and patients with meniscus rupture. In chapter 7, you discuss the biomechanical properties of a meniscal implant. Just last week, the Dutch national guideline on knee arthroscopy was finished, and I was part of that group. A meniscal surgery is performed very frequently, of course, but there's limited place for meniscal implants still in Holland. There's only a couple of surgeons who perform that kind of surgery. What, from a biomechanical standpoint, would be indications for implanting a meniscal implant, do you think?
Okay, thank you. I think meniscus implantation is indeed quite new, especially I think there are only a few meniscus implants available in the market, and one of them, the new surface, was started in clinics since 2016, I believe. And also the meniscus implant developed in our lab by Dr. Fantianen. Also still hasn't been used in clinics. So in that sense, I'm not the one, saying what's the future of the meniscus implant in the meniscus injured patients. But if the surgeon would like to...
But from a biomechanical standpoint, how much resected meniscus would be acceptable, and when would you
that definitely can be verified and studied, but that's all my thesis about. That needs a patient-specific finite element modeling. And as a biomechanical engineer, I'm totally against having or suggesting a general, suggestion. So I think we can, any of those cases, any of patient, we can model them, we can assess how much meniscus tissue can be removed and even whether or not that patient needs to undergo a surgery for implantation or not. All of them can be modeled, simulated, and verified.
Okay, thank you.
Thank you very much. Then it's my pleasure to introduce you to you Dr. Heesterbeek. Dr. Heesterbeek is head of the research lab at the orthopedic research lab at the St. Martin's Clinic in Nijmegen. Please.
Thank you. Dear candidate, first of all, I also wish to congratulate you on your thesis and the work you have done. I also want to congratulate your supervising team. As I'm not an engineer, parts of your book are really difficult to read for me and difficult to understand. However, I found your thesis actually very readable, so compliments for you making such a complex work also accessible for me. You've answered a lot of questions already. I would like to go further on the questions by Dr. Koeta. You would like to have a personalized finite element model for a single patient who is entering the office of Dr. Koeta and he needs an ACL surgery. You sketch quite an extensive workflow in your discussion, and yes. It will take a lot of time also. And I was wondering, did you think about who is going to pay for that? Because I'm sure the insurance companies only reimburse Dr. Koeta by a single small amount of money. And do you have a solution for that?
Dear Honored Madam, thank you very much for your very nice words and for your compliment. In regards to your question, indeed, as also I think mentioned in the discussion chapter, also in the discussion of chapter 6, maybe the main obstacle of performing this study and this workflow in clinic is the time required for workflow computation. And that's why we try to, let's say, have a shortcut for instance, ligament property estimation as studied in chapter 5. And still, we need to improve this study to make it more practical for clinical implementation, and more importantly, in terms of the time required for the workflow completion. And I think that's not yet ready for clinical implementation. So we need to work more to cut the time needed for that. And then we shouldn't be worried of the insurance payment.
I think there's time for some small question left. So time is an issue, and I think you mean also computing power. And some people have calculated that when you express the number of calculations per second that one can buy for $1,000, we can see that there's an exponential growth in computing power, and actually this growth is now progressing more each hour than it did in its entire first 90 years. Mm-hmm. So it's expected to surpass brain power of humans only in 2023. That's in 5 years. Mm-hmm. I find that very fascinating, and I can imagine that you have thoughts about this, how the place of your models are in 5 years?
Yes,
Is
thank
it
you.
going to solve the problem of time?
I think in terms of computer power, it's running quite well, especially with the new techniques of computation, like using GPU or deep learning. I think we can really
You may
improve on
finish your sentence.
that.
Okay.
Thank you.
The defense is herewith concluded. I give the floor once again to the candidate.
Thank you. Having defended my doctoral thesis to the best of my ability, I would like to thank the rector and my supervisor, as well as all those who have honored this ceremony with their presence.
The doctoral examination board retreats for its deliberations. On behalf of the Council of Deans of the Radboud University Nijmegen, we have decided to award you the degree of doctor. I invite Professor van Donschot to discharge the task assigned to him.
We are sure. In the name of the Lord, with the power entrusted by law to the Council of Deans, I hereby confer upon you, Hamid Naghibi Beidokhti, born in Gonabad, the title of Doctor from Radboud University Nijmegen, to which are attached all the associated legal and customary rights and duties with respect to academia and society. As proof thereof, I present you with a doctoral diploma signed by the rector and the doctoral thesis supervisors and co-supervisor.
Please be seated, and I invite Professor van Donschot to give the laudatio.
Dear Hamid, it's an absolute pleasure to be the first to congratulate you with your PhD. And I do that also on behalf of Ton and Dennis. And obviously we include Sarah in these congratulations, as she has been your partner in this big adventure, because it is a big adventure here in Holland. I congratulate your family and friends too, who are now watching live stream. I suppose that they are in Gonabad, are they?
No,
Some of them? No?
but still in the
Well, I
country.
looked up where it is. Gonabad is on the east side of Iran and about 1,000 kilometers from Tehran. So
Yep.
it was at that time already a long way from home. But you can always extend it, you know. You can always go further. Hamid, onze eerste contact gaat terug naar 5 december 2012. Oh, ik praat nu opeens Nederlands. Maakt dat uit voor je?
Not yet.
Hè?
Not yet.
Maakt niks uit? Nee? Okay, Hamid, you did a course Dutch, and you are quite fanatic and structured to generate good results in everything you do. But a Dutch course was the only one thing I could think of which you failed to pass in the last 6 years. That there is a Dutch summary in this thesis is really a small miracle. You used something like Google Translate to generate this. And people who do the inburgingscursus, do you know what an inburgingscursus is?
Checking something? Or?
Yeah, you know. They are not allowed to use Google Translate. But luckily, we have our own translation bureau at the ORL in the form of Dennis Janssen Translate. So, ladies and gentlemen, if you see a spelling mistake in the Dutch summary, do not blame Hamid, but blame Dennis Janssen Translate. Anyway, our first contact was on December 5th, 2012. I looked it up, I found a mail. And you sent your CV by email and expressed that you wanted to join our group. I indicated that we had no budget, but you wrote that you had saved money and could come to Holland. And that showed to us that you were very eager to join our group. So we Skyped with you to get to know each other, and we were impressed about what you have done in biomechanics and how you could discuss about it. And I remember very well that I called you. You were hiking somewhere in nature. Do you remember that?
Yeah.
And in the middle of nowhere. And then I called you that we would supervise you on a PhD project. I knew that phone call would change your life. You were really excited and could almost not believe it. And yes, it did change your life. You started on the 1st of July 2013, about half a year later than our first contact. It was difficult to find housing for you, but Ineke managed to find a place to stay, again, in the middle of nowhere, in the Ooipolder. It was in the middle of nowhere, a little bit. Okay, but it's a very nice place. It turned out that you did not come alone, but that Sarah joined you right away. I really can tell you that I was worried about how she would adapt. Staying there in the middle of nowhere, coming from big cities like Tehran and Berlin, and then somewhere in the Ooipolder. I mean, you could work for 24 hours per day, but what would Sarah do, huh? It turned out that, Sarah, you adapted quite quickly. At least it was my impression. It is probably going a little bit up and down. You had been living in Berlin already and wanted to pursue your career as a photographer. Your work is called narrative staged photography, and I like it so much that we have a big piece of your artwork hanging in my living room. And you also got a job in Amsterdam, and we could always know when you were working in Amsterdam, because at these days Hamid would bring you to the station and he would be in the laboratory before 7 a.m. with very strong coffee to get started, because early mornings are not his favorite times of the day. Sarah, I admire your support for Hamid. It was a true partnership and still is, and it's therefore great to see that Hamid dedicates this thesis to you. But of course this laudatio is for Hamid, so I turn back to you. So before you came, you had saved a lot of Iranian money, right? Not in euros, but in rials. And soon that saving turned out to be less worth than anticipated. And it is very unusual to show a graph. I could make a slide, but I looked it up. So this is the graph of the exchange rate of the rial versus the American dollar. So here Hamid came just before it raised so dramatically. Usually if you see an upgoing curve, it's good, but this was bad news because the money that you saved was less than half of its worth. And so this was because of the American and European sanctions. And there's little we can do. But it's a fact of life. And luckily we managed to get it all sorted out. But what you can also see is here, at the very end, this is basically today, it also goes up, right? So the Iranian sanctions are still present and pressing on savings of Iranian people who come here. So that's not good news for our Iranian friends. I'm sorry about that. Okay, so where am I? Okay, so I think I'm here. So Hamid, you are a dedicated researcher, no nonsense, critical, and certainly very stubborn. And those are very good qualities for a scientist, you know that. Immediately after your arrival, you started to work on a dynamic finite element model, and 5 months later, you had the first version running, which was absolutely an important milestone for the whole Biomech Tools project. So thank you for that. These models needed validation, and you did that by performing cadaver measurements as we saw in the discussions. It is clear that you love computers more than those donor knees, and you basically minimize the amount of time spending in the basement. but you generated in that short time a wealth of data which would allow you to support your models in a unique manner and would also allow to publish all these models with the validation results. At the beginning of your PhD project, you really had to adapt and were reluctant to ask help of anybody. I remember that you needed somebody to drive you with the donor knees to the AMC in Amsterdam for MRI scanning. But because it would become very late in the night, you did not dare to ask anybody. Because in your mind, you cannot ask anybody to sacrifice so much private time. So you waited and waited and waited. So the result was that you did not ask anybody. And one day before the scanning in Amsterdam, you still had no driver. Because your own driving license was not valid here in Holland. Eventually, you asked Richard to drive you. And Richard, of course, had no problem with that. But this example shows that you had to adapt at the beginning of your thesis and maybe in the whole cultural environment of the Netherlands. Currently, you easily ask people to help you. Help for moving to Amersfoort, organize meeting, distribute your thesis, etc., etc. So it seems that you have adapted completely and have become a master in delegating things. And when I thought about that, I thought perhaps some of us can learn from that as well. Hamid, you have grown to be an independent researcher with a clear focus. And now you're working with Momen at the Robotics and Mechatronics Group in Twente. And when I see you acting in Twente, it seems as if you are working there for years, which gives me great pleasure. You are investing your time in simulations of liver cancer treatment, a very important topic with great challenges. I obviously hope that you will be successful, and my door is always open if you need any help. On behalf of the ORL and the Biomech Tools team, I once more congratulate you and wish you and Sarah a bright and happy future. Thank you.
Dear Dr. Naghibi Beidokhti, on behalf of the Council of Deans, I would like to convey my congratulations with the doctorate, and in that I would like to include your partner, your family, also your family in Iran. I hope the streaming went well and they can feel as proud as we are feeling here in this room. I would also like to include in my congratulations the research group at the Radboud University and also the University of Twente, where you are now going to work with this big result. This brings us to the end of this ceremony that in the customs of the university, I would like to finish with a prayer, and I invite you to be standing. Gratias tibi agimus, omnipotens Deus, pro omnibus beneficiis tuis, qui vivis et regnas per omnia saecula saeculorum.